I'm delighted to welcome you to the second day of NASI's 22nd annual conference. We have a terrific agenda today, and I'm glad you are all here to join us and participate in it. It's now my great pleasure to introduce to you our opening speaker for the day, Susan Dentzer. She's going to share with us some wisdom about healthcare reform. We thought way back in the summer when we began planning this conference that we might be looking nostalgically back on health reform. But instead, it's keeping us on the edge of our seats. And we're really looking forward to hearing from Susan. And then after her remarks, we have a panel of people talking about health reform. And we'll go right into that after Susan and her question and answer session. So please stay for that. Okay, I'll tell you a little about Susan. I'll tell you a little bit about Susan, and then please, I encourage you to read more in the biography that you'll find in your packets. Susan Dentzer is the editor-in-chief of the journal Health Affairs, a preeminent journal in health policy. It's also a peer-reviewed journal. And she may be familiar to many of you from many years as an on-air correspondent with the NewsHour with Jim Lara on public broadcasting system television. And she still continues to be an analyst for the NewsHour. She also brings many years of experience writing in print media for U.S. News and World Report. I was interested to see as an economic correspondent, and a whole bunch of other experience in healthcare, economic policy, and all kinds of great things. So without delaying any longer, welcome, Susan.
Thank you very much, Harriet. Good morning to all of you. It's great to be here with you, although when I look at the title like that, Beyond the Bad Economy, Jobs, Retirement, Health, and Social Insurance, and then hear about all the upbeat presentations of yesterday, I'm sure I'm not going to make matters any better for you this morning. Harriet is always good for a laugh line, so previewing that I'll speak with wisdom about healthcare reform is a good laugh line at this juncture. I am happy to be here, though. This is my first year as an Academy member, so I'm delighted to be among your august company this morning, having been an outsider looking in for many years. The conventional wisdom among some is that journalists should retain a sense of professional distance from the subjects they cover and should not become emotionally embroiled in them or attached to them, which I would say is an impossibility if you've been following the healthcare debate as long as I have, or Bob Rosenblatt or others among who are present here today, and not the least of them being those of you who have been working on these issues all these years. Karen Pollitz came up to me and said she's quitting the business and is going to go do something else. Well, how can one not be emotionally invested given what we all know about the topic? I felt very much the same way when healthcare reform fell apart in 1994. I had covered the subject in the 80s. I had covered the run-up to the 1992 campaign. I'd covered Clinton's first months in the White House. I've been through the 500-person task force. I'd gone through the toll gates, up to Capitol Hill, attended innumerable press conferences where people like the august Senator Kennedy proclaimed that the achievement was nearly at hand, et cetera, and then, of course, it all fell apart. And I know a lot of you had the same effect, this had the same effect on a lot of you that it had on me. I, to this day, suffer from a form of post-traumatic health reform stress disorder, where I constantly have flashbacks to this. And needless to say, I'm having a very bad case of, I guess it's PTHSRD at the moment, as a consequence of the events of the last 48 hours. I remember thinking at the time, back in '94, that this was like, the whole experience was like watching the Alfred Hitchcock movie Psycho for the first time. If you remember the movie as a viewer, you think it's a movie about Tony Perkins, a.k.a. Norman Bates, who lives in an old house next door to the family's Bates Motel, and that his elderly mother sits up in the attic in her rocking chair all day throughout the course of the movie. By the end of the movie, after Janet Leigh has been stabbed in the shower and after lots of other gory action, you realize that actually Tony Perkins, Norman Bates, is totally batso, and his elderly mother is actually the corpse of his elderly mother, and she has been dead the entire movie. You just didn't know it because you've always seen her from the back. I felt healthcare reform was like that. It had been dead the whole movie, and I just didn't know it. And we were running around as if there was really something alive about it, and in fact, that was not the case. I'm having a little bit of that, a recurrence of that feeling now. In fact, I'm grappling to figure out, is there a movie that could possibly encapsulate the events of the past year and the dramatic scope of a situation where the Lion of the Senate dies of brain cancer halfway through the process, and his seat is taken by a man who posed nude in Cosmo. I can't come up with that movie. Maybe you can. The best I can do is say maybe we could go with the title, It's Complicated. So like many of you, over the past 48 hours, I've been engaging in guessing games about what is the path forward at this point, and we know we're all reading about the same series of conjectures about the path forward, all kinds of semi-plausible scenarios about scaling back bills, focusing on the 80% of common ground that people in both parties agree on. I must say, to quote my friend David Brooks, when you hear people talk about the common ground, it actually sounds more like common pebbles. If anything, it doesn't sound like it's very, very much. I have the very sneaky feeling that many of you will have also, that there are some influential people in the party out of power who have now tasted blood and have already concluded they have absolutely no reason to cooperate to pass even a very watered-down bill until after they seize as many seats back as possible in the forthcoming November elections. So all of this makes me rather dubious that something can be pulled out of the fire at this point. I hope very much to be proven wrong. I really hope we can see our way clear to passing legislation that grapples with more than just the easy points of consensus, which, if you look at the list, there was a piece in today's Times, I think, that talked about the lists of consensus, and it's a pretty thin gruel, so I hope we get beyond that, and I hope we prove wrong the analysts who say and have been writing that they believe that the governmental mechanism that the Founding Fathers left to us, the two houses of Congress, a Senate that where each state has equal representation regardless of whether they have 10 people in the state or somewhat more than that, that the unique damper that the Founding Fathers dreamed up, known as the filibuster on the passions, cooling the passions of the House in the august Senate, that all of that is no longer the equal of passing very complex social legislation. I hope that view also can ultimately be proven wrong, although I suspect there's a lot of truth to it. So I find myself grasping at straws, trying to persuade myself that there is, in fact, a dedicated group of policymakers and policy influentials that has learned something so profound over the past couple of years that this will not be lost, and that awarenesses have also developed among the public that are so powerful now that we as Americans will not permit ourselves to go through another 15 years in the wilderness. Even if we don't do it in one fell swoop, even if we have to carve it up into a series of bills that we enact over the next several years, as some have suggested. So, what do I hope those awarenesses are? Well, borrowing from another current human screw-up in the news, which is the shake-up in late-night television, I have developed my own list of the top 10, I call them sort of underlying awarenesses, that I think the past several years have very vividly reinforced, and that I believe we have to keep front and center. All of us who care about these issues have to keep front and center over the next several months. Now, nothing I'm about to say is new. It all could have been said 15 years ago, 30 years ago. Much of it was said 15 and 30 years ago, not to mention 70 years ago or more. I think back to the Commission on the Cost of Medical Care during the Hoover era. You can basically take their conclusions out today, and they're as applicable then as they were now. Nonetheless, these are truisms, I believe, and they, for all the apparent resistance among some parts of the public to profound change, at the core of these truths, I think, are the elements that we have to build on to rebuild a basis of support for very meaningful change. So here is my list of the top 10 underlying awarenesses. Again, not pretending that these are new, but starting with number 10. Turns out the U.S. doesn't really have the greatest health care system in the world after all. You are shocked to know this. It doesn't have the worst one either. It probably has the most uneven one. with the greatest gap of any system between the money we spend on it and the outcomes we achieve. I do think this awareness, while many of us have had it for quite some time, decades or more, I believe there's an element of newness in this for the American public that is new and different from 1993 and 1994. Do I have a lot of data that demonstrates this? No, it's mainly subjective. It's what I hear in conversations with people when I'm traveling around the country. One data point I'll give you, just take Atul Gawande's piece in the New Yorker last spring on Waco, Texas, telling the age-old story of the regional variations in healthcare, once again, that Jack Wenberg and the Dartmouth Atlas crowd have been telling with data for 3 decades. So this year it takes off. Now maybe it takes off just among a policy elite, but it captures the imagination graphically as we understand the unevenness in the system. And building on top of 10 years of the Institute of Medicine report on lack of safety, everything else, all of the data of the last 10 and 15 years, I believe now there's greater willingness than ever among Americans to accept the fact that our system, for all its extraordinary achievements, has serious flaws that public policy has a duty to address. So I call that number 10. Number 9, system, again, this will shock you, the system as we know it is not sustainable. I don't just mean in a fiscal sense, although that is obvious. I mean in a societal sense. David Cutler is here today. We published an update of the research that he and Mike Chernow, his colleague at Harvard, and Richard Hirsch at University of Michigan had done several years ago. We published an update in our Bending the Cost Curve issue in September, October in Health Affairs, and we asked them to revisit projections about what would happen if U.S. health spending continues at 2 percentage points faster than real per capita GDP growth over the next 75 years. The answer is, if this continues over the next 75 years, 119% of the entire increase in per capita income over that period will go into health care. 119%, which of course is a way of saying every additional dollar the economy generates in economic well-being plus some. Plus resources that we're currently expending on other sources. Now, obviously, this is, to some degree, as David would be the first to acknowledge, a fantastical scenario because who can predict 2 months into the future, let alone 75 years. But just think about that trajectory that we're on and think about what that portends for the nation's ability to invest in the other things that we care about, education, infrastructure, not to mention defense. I cannot imagine a world that would result 75 years from now. I heard the Pastor Jim Wallace on Stephen Colbert the other night say he's longing for the days when we talked, as the Native American Indians did, about the 7th generation, policies, thinking about what we would do today that would affect the 7th generation. Just think about, you don't even have to go out 7 generations, just go out 1 or 2. And imagine a world where almost everybody, imagine a country where almost everybody is either in the business of delivering health care or getting it, and not much else. Do you want your kids or grandchildren or great-grandchildren to live in that world? I don't. I don't. So we know fundamentally, societally, this is unsustainable. I'm not sure the awareness of this is universal. If it were, I think you would have seen a different reaction to the unions who were opposing setting an upper limit on the tax exclusion of health insurance, because they would have recognized that they have given up a good deal of wage income over the last several decades in order to make growing income transfers to the healthcare sector. Now, it's one thing to have rich health insurance benefits, I get that, but you put that together with what we have done to fuel the growth of the healthcare industrial complex. If I were a union worker, I'd be a little bit more cognizant of that than many appear to be. So it's not a universal realization, but I do think at some level the awareness is there, and I hope growing. Number 8, we know we have done a really fantastic job of creating a sickness care system in the United States. We now have to create the front half of that, which is the wellness care system. We know this, again, it's almost politically unassailable. Both Obama and McCain talked about prevention at length during the course of the campaign. It is The notion of preserving and prolonging health, I think, is truly a bipartisan goal. We could do this, if you look through the House and Senate bills, there are a lot of very important prevention pieces in it, notwithstanding that those bills keep getting dissed as about nothing other than health insurance reform. That is just simply a lie. You go through, and there's some very important provisions that deal with other things than health insurance, as we know. One of them is pushing the system more and more, orienting it toward prevention. And whether we continue to do this by inserting with a crowbar more preventive coverage for preventive services into Medicare, or giving employers the ability to incentivize healthy behavior among their workers by giving them discounts on their health insurance or whatever, we know that there's basically an across-the-board agreement now that we've got to push the system more and more toward prevention and preservation of health. And again, I think that's universal, and I think that's a very important conclusion we can continue to build on. Number 7, incentives matter. Again, a no-brainer. We get what we pay for. If we pay for care on a piecework basis, we get piecework health care. We need to come up with new or modified ways to pay organized systems of providers to coordinate care, to take on risk, and be rewarded for improving population health outcomes. This is the conclusion that Massachusetts Special Payment Commission landed on. Global payment twinned to measurable health outcomes achieved by organized systems. This is why there's been so much talk over the last couple of years about bundled payments, about accountable care organizations. This is already underway and will continue. Not a day goes by at Health Affairs that we don't become aware of new entities, hospital systems, healthcare systems across the country that are organizing themselves as integrated care delivery systems and trying to put in place, even independent of anything that happens with healthcare reform, arguing for more of the ability to operate under a bundled payment environment and looking for ways to structure that business on the private side, no matter what we do or don't do on the public side through Medicare, et cetera, because they understand this is the way to go, and they want to go this way. So this very powerful force has been unleashed in the current health reform debate, and I think it's going to be sustained even if the whole enterprise in Congress falls apart. I hope it doesn't fall apart. I think it's critically important that the federal government take the lead by shifting the incentives and innovating in this way, and God help us if what doesn't come forward is some enhanced ability, or not even enhanced ability, instruction to the Secretary, just as the bills now say, the Secretary shall have these pilot projects in these arenas, accountable care organizations, et cetera, to push the system more in this direction. Number 8, very closely correlated, the delivery system matters. And this is so tightly correlated because, of course, we know if we reshape the incentives, the delivery redesign would probably follow. Most particularly, I think what would come out of that would be a natural re-emphasis on primary care. We're going to come out with a special issue on reinventing primary care in May. It's going to repeat the evidence, which is pretty clear, that systems that focus more of their resources on primary care get better outcomes and more cost effectively. We know that this doesn't happen magically. We know it has to happen as an instrument of public policy. The United Kingdom undertook this several years ago when it drastically raised salaries in the NHS for primary care physicians. So we know this is going to require some public policy moves to push the incentives around, to push the reconfiguration of the delivery system. We also know we have untapped potential in a whole core of people whom the current system has, frankly, disincentivized to provide primary care, whether they are advanced practice nurses, physician assistants, others, non-physician providers who will participate in patient-centered medical homes, et cetera, that we could certainly produce a core of primary care providers who were non-physicians much faster, much more cheaply, and people who would be much more inclined, I think, probably to stick with it as opposed to gravitating off into areas of specialty care, or what I increasingly hear referred to as partialist care as opposed to primary care. Number 7, again correlated with this, budgets matter. We know that you can accomplish a lot in life in terms of streamlining and efficiencies if you know you've only got a certain set of budget. I don't think this country is ever going to go to a national global budget for health care, because I think that would force us to make too many tough decisions too quickly. But global payments are a way of putting budgets around system. And so again, capitation tied to meeting health metrics is a potential way out of our current problem. And so the more we move to budgeting the system in some way and forcing people to improvise within a pool of funds, the farther we'll get. Number 6, prices matter. The McKinsey analyses of the last couple of years show unequivocally that a good deal of our excess spending in health care is the prices we pay and that we seem to be willing to pay vis-a-vis other countries. We have got to find a way to continue to squeeze down on prices in health care. I don't think we're going to get that way entirely through a price control regimen, nor, of course, do we know necessarily that that might be advisable. But we have got to look at the mechanisms that we have used successfully in the past to push down the price level in various arenas. And I give you the example of Hatch-Waxman, the growth of generic medications. Very important piece in the health care bills is the transition to follow-on biologics for the new biological drugs and creating generic equivalents in effect of those. If health care reform goes down, I don't know what the vehicle is that passes that through over the next couple of years or so, but it's critically important, and we have got to continue to look at ways to force down the price level or to encourage the formation of businesses, entrance into the marketplace of entities that see their business model as capturing profits off of the efforts to lower costs in the overall healthcare system as opposed to increasing them. Number 5, don't forget about long-term care. Again, one of the great achievements to me of the current health reform bills is that the CLASS Act, the so-called Community Living Assistance Supports and Services provisions, made it in there. Now, you may quarrel, as many have, with some of the financial underpinnings of that construct, and a lot of work was done after the bills were passed in the Senate and the House to continue to refine it. And I think if we had seen the final Senate bill come out, you would have seen some of the final details emerge that would have made that a sounder fiscal proposition. But just because we have siloed off long-term care from acute care in an increasingly inane fashion doesn't mean that those needs don't continue to exist. And we have got to keep at it to create a mechanism of support for the millions in this country who will continue to need home-based community support to live in their homes with extreme amounts of disability, whether they are young or whether they are old. Number 4, I think, is in our system, coverage matters. We can debate till the cows come home whether the insurance model of health insurance was the right model around which to organize health care in the United States, but the fact is we did it. And although we can do a lot to provide care for uninsured populations through community health centers and so forth, in the end we have got to keep at the notion of expanding coverage for people. It is the only way they will have true access to the U.S. healthcare system. Again, we can think about these fallback mechanisms. Healthy San Francisco, the program in San Francisco, the framers of that looked at the cost of providing coverage to people in San Francisco and decided it was too expensive, so they fell back on providing care through the clinic construct. We're obviously going to have to continue to do that to some degree, but we cannot let go of the notion of getting coverage to people. And we will need to expand. We know we're going to have to do this on the public side for low-income populations. There is no way we're going to be willing to come up with subsidies large enough to support private coverage for low-income populations. We are going to have to expand Medicaid and CHIP. Related to that, number 3 is we're going to have to continue to rethink federalism insofar as the provision of health care and coverage is concerned. I would argue that the so-called Louisiana Purchase and the Cornhusker Hustle, the special deals granted Louisiana and Nebraska, to get those senators, respective senators, to vote for health reform, graphically underscore this. You could say this, write this off as just cynical dealings of backroom government. You could also say this is because of the screwed up way the current federalist system, particularly as evidenced in Medicaid, is addressing the problem of providing coverage among very different states with very different levels of income. We have got to keep working at coming up with a better formula for the shared responsibility between the states and the federal government. It's not magic yet. It certainly wasn't magic in the final versions of the health reform legislation, but we've got to keep at that. Number two, I would say, is we know, again, it's about health, stupid, not just health care. We clearly have abandoned the notion of public health in this country at our peril. And this has come home to me in spades, just on a personal note, for the last several months. I'm thinking a lot these days about how tepid a battle we waged for as many years as we did against tobacco, which, thank God, eventually escalated into an all-out war. So now, after 4 decades, of at least 2 of which probably was arguably an all-out war, we finally got down to the point where 1 in 5 adult Americans is smoking, down from 1 in 2. But we know that tobacco is still the #1 cause of preventable death in America. And just in the past year, I've lost an elderly aunt to tobacco-induced emphysema, for which she battled for about 15 years. The disparity between my now dead 80-year-old aunt and my 79-year-old mother, who never smoked, is not to be believed. My mother is hale and hearty and healthy at 79. My aunt is dead and suffered 15 years of very poor quality of life. That was bad enough, but then just 3 weeks ago, my younger sister was diagnosed with very advanced extensive lung cancer after several decades of smoking. She quit last February. She got health insurance in January after being unemployed for a while and having lost her COBRA coverage. And in September, she developed a great deal of hoarseness. By November, we knew it was something serious. December 27th, we found out it was advanced lung cancer that metastasized to her bones and her brain. Why did we abandon the fight on tobacco? And now we are seeing the same thing in obesity, the same crises being set up because we are not willing to step up to the forces that are conditioning the environment to decades, if not centuries, of extreme poor health for the nation's children and for adults. We have got to come back to public health. Number one, and I'll close on this note. Now, I've just been through all the very sound fiscal and economic reasons to do this, and I take these very seriously, as you know, as I know all of you do. I really do feel these increasingly resonate with a lot of the public. But let's not forget these old moral imperatives, these old values. And these are the things that keep floating back through my head. Several years ago, when I was still at the NewsHour, I did stories about an organization called Remote Area Medical. And a fellow named Stan Brock, who is a British guy in his 70s, you may dimly remember him because he was one of the alligator wrestlers years ago on Wild Kingdom. His organization today, he came to the United States a number of years ago. He set up an organization that actually was designed to fly around to remote parts of the world and provide health care. He had spent a lot of time in the Amazon, gotten very attached to the Indians of the Amazon, wanted to give back and develop this organization. He started off helping people in the Amazon. He started flying to parts of the former Soviet Union, et cetera, et cetera. I first encountered this organization in New Orleans after Hurricane Katrina, where they were down there doing one of their emergency 3-day health care, giveaway free health care events for people. I subsequently did a piece on them about a fair they hold annually down in Wise County, Virginia, where we were there for several days. The first day of the fair that we covered, about 2,000 people showed up to get free health care delivered by an array of providers. They had to cut off the line the first day at 1,200 people. People had driven in from Ohio and Alabama to this fair to get free health care. I saw a woman who got her first mammogram at the age of 68. The reason she got a mammogram is she had a small grapefruit-sized tumor on the side of her breast that she thought might be something important, et cetera, et cetera. It was just an incredibly gripping experience. Now, this was public television, and my friend Tom Brokaw refers to us as eat your peas television. We give people the stuff, that a lot of the networks tend to gloss over. I was very gratified, actually. We did these pieces several years ago. I was very gratified last year to see the same organization finally profiled in 60 Minutes. And then a few weeks later, Stan Brock, this crusty 78-year-old Brit, was named Person of the Week on ABC. I thought that said something. I thought that said that this is permeated through the U.S. consciousness. Stan Brock talks about U.S. healthcare with the same authority and authenticity, I think, that de Tocqueville had in telling Americans about themselves. And he said to me back in 2007 at the Wise County Fair with very classically deft English understatement, he said, "It's very sad, of course, that the state of affairs requires us to provide this kind of care in the world's richest country." And he was quickly echoed by a physician from the University of Virginia who was there providing free health care on leave of absence from UVA, saying, "The fact that we have to be here at all is a real indictment of the healthcare system. Instead of giving comprehensive care, we're putting a Band-Aid on the problem. And although I'm happy to be here," Dr. Nut Carney said, "I really wish that we wouldn't have to come at all." Well, I think these encapsulated therein are the same sentiments of outrage, of empathy, of human compassion that side by side with our very sensible concerns about the fiscal future of our nation laid the foundations for social insurance systems years ago around the world and here in the United States. And despite all the other influences in our society and our culture that point us the opposite way, away from social insurance, I don't think these are dead. And I don't think we can let them die. So I salute all of you who are here today who feel this way also. I urge us all to use all of the tools at our disposal to make sure that this nation takes a major step forward in healthcare reform this year. Thank you very much.
Hi. I'd like to invite questions. If you would like to ask a question, there are 2 standing microphones, and I'd appreciate your going to them. But we also have a traveling microphone if you'd like a microphone to come to you. Yeah. Raise your hand and we can bring one to you. So we'll do 2 questions, I think, because we're low on time, but I want to have this opportunity. And please identify yourself.
Hi, Glenn Springstead from the Social Security Administration. My question is, there was a Senate bill that was passed. Is that correct?
Yes. Bills have passed both the House and the Senate.
Right. And the House could, in theory, simply pass the Senate bill. But that doesn't seem to be, that's another thing that just seems to be a very odd sort of non-starter.
Right.
And there's a fairly healthy Democratic majority in the House. So, could you address why you don't think that they seem willing to step up to the plate to do that?
I think on the House side, Congresswoman Pelosi said, Speaker Pelosi said yesterday that she could not muster the votes for the Senate bill. And I think the split comes on 2 sides. One is there's a very dedicated left-wing core of House Democrats who don't like some very specific provisions of the Senate bill, which are not easy to summarize, but they range from the fact that the subsidies are much lower than in the House bill for provision of coverage, the excise tax on high-cost health insurance plans, you name it. They really, really hate those provisions and don't think that those would be rectified. They believe that the promise to come back with separate legislation and correct those later is a pig in a poke, and they don't buy it. Then there's a core of more conservative Democrats who, many of whom were just elected for the first time to traditionally Republican seats, who went grudgingly along with the passage of the House bill, thinking that they would be bailed out by the Senate bill, but who now are even less in favor of the Senate bill, given what they've seen in the election results of the past couple of months, and increasingly worried about that, and just not so concerned that, or not so convinced that it isn't a better idea to go back to the drawing board. So between those two groups of the lack of support on the part of the left, the lack of support on the part of the more conservative Democrats, she just doesn't have the votes. So it looks like that strategy is dead. Now, you never say never in Washington. As long as people keep talking, who knows what could happen. But at the moment, I as of today, you wouldn't bet on that strategy prevailing. So.
Wei Wenung, visiting scholar with NASI. Many political scientists would argue that the U.S. is a center-right country culturally. How do we sell the skeptics the social insurance approach for health care? In particular, I didn't get to ask this question of the long-term care roundtable. How do we sell the social insurance approach for long-term care? The UK, which is a European country with almost government-run health care, which is culturally similar to the U.S., they also use a welfare system for long-term care. So how do we make that sell?
Right. Well, we could start with the question of whether this is, in fact, a center-right country or not. I mean, it's very clear it's a polarized country at the moment, and therefore a lot of emphasis is placed on governing from the center as the only workable way of dealing with such a polarized country. Tell the folks who support MoveOn.org that it's a center-right country. I don't think you'll get a lot of agreement on that. So, leaving that aside, how do you sell the concept of social insurance? First of all, I don't think you call it that, frankly. It's clear that the word social makes a lot of people nervous. God knows what reason. It's possibly because of its close relative social list. But I think when you describe the programs, people like them. People love Social Security, which manages to survive notwithstanding its name. People liked the description of the Class Act, which is a social insurance program. So when you describe these things to people, and you basically describe the notion that what we're doing is we're creating the ability of people to set aside, it sort of harkens back to early primitive human existence. In times of plenty, you set aside something for use in times of want. And I think people inherently kind of get that, and they kind of get that you have to do that. Not everybody. Of course, there's a lot of people, I guess, who still are going to believe that individual accounts in Social Security would make a really good program after what we've been through the last few years. But more people than not, I think, get that we have to kind of do this in a collectivist fashion, even if we don't call it that. So I think you just describe the mechanisms, you point to the things that work and that people value that are already out there, and you say, we could also potentially build on these. And by the way, systems that have tended to put an emphasis lately on people providing for themselves haven't held up under the pressures of financial crises, market swings, a global economy, increasing uncertainty about the future of employment, et cetera, et cetera. So I think that's how you frame it. Thank you very much. I enjoyed being with you today.
Hi. We're going to move right into the health reform panel. So speakers, please come on up. There you are. Good. Great.
It's one thing. It's another thing to be today here where we are. The title of our talk is still quite relevant, a look at health care reform and what remains to be done. So that's how it was framed way long ago. There are many ways to take this apart, and I think the fact that we have such a distinguished panel of people to address this from what they might have planned to say, coupled with their ability to reframe where we are today. So you have their bios. I'm going to just read off their names so that we can get going. You all know them quite well. Judy Feder is the Senior Fellow at the Center for American Progress. Karen Pollitz is Project Director at the Institute for Healthcare Research and Policy at Georgetown. David Cutler is the Otto Eckstein Professor of Applied Economics in the Department of Economics at Harvard University, the JFK School of Government. Brian Smedley is Vice President and Director of Health Policy Institute of the Joint Center for Political and Economic Studies. Kenneth Porter is the Senior Vice President, International Benefits and Chief Actuary of the American Benefits Council. So they're each scheduled to speak for 10 minutes, and then we'll have a chance to have some questions at the end before we break for lunch and have our special memorial to Senator Kennedy, and that event will be moderated by Peter Edelman of Georgetown University Law Center. So I will, at this point, be expeditious and start right off with Judy.
Thank you, Jenny. And as Jenny said, we need to have a little bit of flexibility in what we're talking about this morning. This is not the talk I intended to give. And I also would like to say that following Susan's tour de force, we're going to see something completely different, but that's okay. That's, I think, what is needed this morning for all of us, or many of us who are veterans in battles of health reform, is to acknowledge that although we are used to ups and downs in this process, where we are now kind of takes your breath away. That health reform should be endangered by Senator Kennedy's death is cosmically unjust and unfair, and does indeed take our breath away. So what I think is needed for next steps is to take a deep breath, get a grip, and in contrast, taking a slightly different tone from Susan's answer to, I think it was Glenn's question, by hook or by crook, pass that Senate bill. Now, when I say that, I know that neither progressives nor moderates, and I will call us left and right because I can't think of better labels, but forget the right. I'm talking about the right in the Democratic Party. Not on both sides, we've not been very happy with the Senate bill. And I am certainly in the camp of those who would like to see significant improvements in that bill as we legislate, please God, a piece of health reform. But I thought it was useful this morning to remind both the left and the right what is in that bill in case any of us, and I have heard some say, that that nothing would be superior to its passage. And I want to dramatically distance myself from that point of view and remind everybody what's in it. So let's start with the coverage piece, which, and I believe with Susan that is the number one issue. On the left, there is no doubt that we would like to see universal coverage. This ain't it. But covering more than 30 million people is a pretty dramatic step. And covering about half of them, as the Senate bill would do, amazingly, in a Medicaid expansion, while perhaps not our preferred choice, would do away once and for all with the categories of deserving and undeserving poor that are a vestige of the welfare system, plague health insurance coverage for low-income people, by covering everybody across the board, regardless of what kind of family you're in, as long as your income is below 133% of poverty. That is not an achievement to sneeze at. And while we, on the left, are worried about insufficient subsidies and inadequate benefits, sure, we'd like to do better. But the right should recognize this is not a Cadillac plan we're offering. Even the new senator from Massachusetts has said that everybody in this country should have a core of health care benefit protection. And let's face it, that's about what the Senate bill is providing. Next up for me, in terms of what this bill offers, are the opportunity for changing insurance industry behavior. Now, there's nobody who knows more about their bad behavior or has fought harder to bring it to an end than my Georgetown colleague, Karen Pollitz, who's a national resource on this topic. And I've heard her for years pose a question to the insurance industry, which really is a problem. What part of no do they not understand? Now, they're very good at not understanding new rules, intentionally not understanding rules that try to limit their cherry-picking, rescissions, and a whole host of bad stuff. And the Senate bill doesn't do quite enough to hit them over the head with that 2x4 that Karen wields so powerfully. And counting on every single state, as the Senate bill does, to set up a health insurance exchange with a responsive, consumer-friendly, well-regulated insurance marketplace is, let's face it, a bit of a stretch. So, to the moderates, whom I call the right, not to worry. Government hasn't taken over the healthcare industry. We've left plenty of room for the capacity for insurance industry's innovative behavior. But for progressives, for the left, we are changing the rules for insurance, creating an expectation of performance that through a combination of rules and transparency provisions that are in the Senate bill, build in the capacity to hold insurers accountable to those performance rules. It is not single payer, once again, but the opportunity for accountable multiple payers is way better than the freewheeling black boxes we've got operating today. And then there's cost containment. I've been very frustrated by the endless complaints that this legislation does not do enough to control costs. It comes most aggressively from those who have opposed the establishment of a public plan, which probably, if strong, would have done the most to control costs. And God knows this bill leaves consumers with enough skin in the game to make marketeers happy about the ability to contain costs. But as Susan said, short of putting a lid on the system, which some of us have been known to advocate in the past, this bill actually does put in motion the changes in payment and delivery that we need to undertake to move us away from fee-for-service to coordinated, integrated care. And I would just say a word to Dave about another member of the panel, David Cutler, who is a profound believer that we can do it and a committed activist in making us get to that point. Now, much that's in the legislation we really need to make that happen. But the real challenge here in terms of what we do next is to make the Centers for Medicare and Medicaid Services an agency not known for its energetic, real-time, innovative capacity. And I suspect the people who just laughed work for it, so we know that well. We've got to turn CMS into the engine of reform that it needs to be to get us value for the dollar in health care. And what makes me optimistic about achieving that goal is that we pretty much have no choice. Either we get our health care costs under control, with or without health reform, or affordable coverage is up a creek. Absorbing that imperative and putting effective, accountable payment mechanisms into place isn't about left or right. It is about our only option. Now, along with these three big benefits from the Senate bill, I want to add one often missed, which was on Susan's list, and that is the Class Act, along with other provisions to improve long-term supports and services that are in the Senate legislation. Now, I've always been regarded as something of a Renaissance woman in the healthcare field, being an advocate and an analyst for both health and long-term care. But even I didn't think that this health reform legislation was going to carry with it a pretty close to social insurance type plan, a program for the provision of long-term care. And one of the many reasons I desperately want this bill to pass is that I look forward to telling the story of how sometimes magic happens. Because if we get the Class Act, that is a story about magic in healthcare policy that should inspire even the most despairing of advocates. Taking these things together, along with a host of other provisions in the healthcare bill that Susan alluded to as well, that are too numerous to mention, I want to conclude by saying that the most important reason for passing this bill is that it finally would establish national federal responsibility for assuring Americans affordable health care that we have, those who came before us, have fought for about 100 years. And if we let it go, if health reform goes down, we will not get another chance until my 2-year-old twin granddaughters are grown-ups. That is not okay. So take a breath, get a grip, grit your teeth if you have to, but get out there and get them to pass this bill. Thanks.
Morning. Two by four, huh? I come today unarmed. I don't have a 2x4 to wave at the industry or the Congress or even my teenage children. So thank you for listening, because I guess that's all I get. I'm supposed to talk about how the accomplishments of health reform will change the private insurance industry. Okay, so we already agreed that was a little premature. So I want to shift the focus. I brought essentially the same slides, but shift the focus to why that Senate bill, as imperfect as it is, could still bring about important change. So the key accomplishments of health reform. This was where I was to begin. I put a little asterisk next to it. That's what they do in the sports statistics, right, when it isn't real or it hasn't really happened. Did you, by the way, did you see the editorial cartoon in the Post today, everybody, this morning? The Tom totals? Any football fans? It's got the Democratic football healthcare reform team on the field in a huddle. And the quarterback says, okay, it's the last play of the game. It's 4th and 1 inch. We're behind by 5 points. What do you think? Field goal or punt? Kind of distort the whole system. So it's not perfect, but it is there. And there is also language in the legislation that would monitor access to health care and why it is that people are staying out, what affordability problems are there. And there is an opportunity, particularly if the Congress can manage to pass another reconciliation bill this year that only takes 50 votes in addition to the Senate bill, there is an opportunity to strengthen the subsidy. So I think we have an argument to move forward and expand markets, getting what we can on the subsidy front. The market rules in the Senate bill, also not perfect. I don't know if you can see this. It's a big ballroom. This is a little tchotchke that I picked up at an industry conference. I go to these sometimes. That's how I learn stuff. It's a little dartboard, little magnetic dartboard that has decline, rider, rate up on it. and then the bullseye in the middle is issue coverage. You just sort of throw a dart at it. This was just a little toy that someone was giving out as a marketing gizmo at an industry thing, but I think this is actually a pretty good little model of our current private health insurance system today, and we need to stop doing that. So the Senate bill would require health insurers to guarantee issue coverage, not turn people down because they're sick, to offer them modified community rating, to not exclude their pre-existing conditions. It would again prohibit rescissions. In fact, we prohibited rescissions in 1996 with HIPAA. I'll come back to that in a minute. But it would prohibit them again. And there are some exceptions, unfortunately. These rules are not airtight. My 2x4, my what part of no don't you understand theory didn't quite get into the Senate bill, but so people could continue to pay a lot more based on age. I'm so thrilled with age rating now that I'm in my 50s. 3 times more I could pay because I'm a baby boomer compared to my college-age son. Wellness, Susan talked about wellness. There are surcharges for wellness. We all like wellness, right? Well, the way these are written, it's kind of a little loophole for underwriting. So instead of charging people more because they're sick, under the Senate bill, insurers could charge them more because they're not well. That's a problem. Also, a lot more. The surcharge up to 50% of the cost of the health plan. Smokers would also pay more on top of the wellness surcharge, so they're doubly not well. And, you know, we want to discourage smoking, but meanwhile, we could also discourage smokers from having health insurance, so I'm a little concerned about that. The rules don't apply in the group market for firms above 100 employees, and that could be a problem. And there are still loopholes. The rules don't apply for other kinds of pooling arrangements, association health plans, self-funded plans, MEWAs, and student health plans. So we have some work to do on the Senate language, however. There is an opportunity, if even these rules were implemented, to monitor what's going on in risk selection in the group market and in the individual market, to really measure and see what's going on. There's very strong transparency language in the Senate bill, gorgeous language Senator Rockefeller put in. So whatever else the insurance companies continue to do under these loopholes, you can see it now. Regulators can see it. It has to be disclosed. We can study it. I don't have to keep sneaking into industry meetings to, like, hear stuff. It would be out there. It would be data, and we could use it, and that would be important. And I think that would offer an opportunity to make a case down the road to come back and plug some of these loopholes and make the rules stronger. There's a benefit standard in the Senate bill. The current federal law definition of health insurance is anything a health insurance company sells. So that wouldn't continue under the Senate bill. Now, actual coverage, real benefits that people need when they're sick would have to be included in the plans. Prevention would have to be covered first dollar, which is great. Still some problems in the Senate language. The annual lifetime limits, prohibitions, big loophole on that. So dollar limits would be prohibited, but it would still be okay to say, well, I'll only cover 30 visits lifetime of this kind of service. That's a problem. There are very, very high cost sharing under the Senate bill, so people could still pay thousands of dollars out of pocket every year for services that are covered. And if you have to go out of network, which happens sometimes when you get really sick, that could be a problem. But again, the transparency language, very important in the Senate bill. There would be opportunities to actually measure and track medical debt, uncompensated care, and to come back down the road and make a really good case based on data about what's happening to people under this benefit standard and potentially strengthen it. The exchanges. The new organized marketplaces, very important. Insurance marketplaces today, I don't even know why we call it that. And I mean, economists should just say, no, you can't use that word. This is not a market. There's no transparency. There's no information. It's very hard for people to get coverage, to understand what their choices are, all kinds of barriers to moving around for purchasers in marketplaces, and that would change. So there would be exchanges, and you would have to be, in order to sell coverage, you'd have to be certified as a plan that follows the rules, that offers the basic benefit packages. There would be a lot of consumer assistance. There would be subsidies, the exchanges where you get the subsidies. There would be risk adjustments applied back and forth to help correct for some of the risk selection problems that may continue. And all of that is very important. Under the Senate bill, as Judy mentioned, each state would have to do its own exchange, and that could be a problem because this is going to be very complicated, and it really does need to work well. So, so that could be tricky. But ultimately, the authority for exchanges, this is congressional legislation, rests with the federal government. So I think there's a way to kind of work around this as well. And HHS could develop a template, kind of an exchange in a box, and say to the states, here, this is what you should be doing. And you certainly can do something different if you want to, but you need to come in and apply for a waiver to do something different and show us how you're not going to, mess it up. And that there could be a whole lot, and in fact there is required under the Senate bill, a lot of very careful oversight and auditing of how the money is flowing through the exchanges. So I think we could probably find a way to make the state exchanges work. And finally, we're going to have all these new market rules, so we don't do this anymore. But the rules don't matter if they're not enforced. I mentioned that with HIPAA in 1996, we outlawed rescission. We said, Congress said, federal law, health insurance has to be guaranteed renewable. It has to be renewed at the option of the policyholder. You can't take it back because they get sick. And yet, health insurers are still taking the policy back when you get sick. Why is that? Because nobody gives a damn in Washington. There is nobody at HHS. There is not an Office of Federal Health Insurance Oversight at HHS. There started to be one at the beginning of the Clinton administration, just for about 11 months, and then it got disorganized or reorganized out of existence, and there's nobody there. Nobody checks. Nobody knows what the state laws are, whether the states are implementing the federal law. Under federal law, HHS, the secretary, is to enforce the HIPAA standards for private health insurance if the states aren't doing it. Well, how's that going to happen if nobody checks? So the Senate bill writes all of these new market reforms in the HIPAA structure, still federal fallback, not so happy about that. So we're still going to kind of leave it to the states. But we don't need to let the federal oversight be non-existent. We could fix that too. So even with the Senate bill, if there could be some resources at HHS to hire some people, I know a few names I would suggest, then there could be a lot more proactive, vigorous oversight of what's going on in private markets and how are states doing at enforcing the new, stronger federal standards. So you could actually make that work too. So with that, I would say that while I appreciate the fact that the House bill is stronger on many of these scores and would make it easier, straightforward, a little less scary to
is substantially more administratively costly than it needs to be, and Karen was talking a little bit about this. We have more office workers in healthcare than we have nurses. We have more managers than we have physicians. All those middle managers who were fired from every other industry, I've discovered what happened to them in life. Every single one of them is now employed in the healthcare industry and doing quite well at it. Sometimes they work for, in the healthcare industry, you can have one firm which writes computer software to deny, for insurers to deny payments to doctors, and the same company write computer softwares for doctors to get paid by insurance companies. That's an example of all of this, as well as what happens inside doctors' offices and hospitals, enormous amounts of administrative costs. Second, there are too many acute care episodes. I've shown you just one example of that here. This is the share of people who are rehospitalized, Medicare beneficiaries who are rehospitalized within 30 days of a hospital discharge. The national average rate is about 20%. The range is somewhere from about 15% to 30%. In the best healthcare systems, it's about 6%. All those rehospitalizations are not because the patients want them. I'll give you a big hint. They don't actually want them. And it's not because it's cheaper than caring for people outside of them. I'll give you a hint. It is much more expensive. It is because the system doesn't work very well. A third example, when people do get sick, even if they're in the right sort of setting, they will often get too much care, not the right amount. What this chart on the right shows you is looking at areas of the country based on how much do they spend. The Q1s are the lowest spenders, the Q5s are the highest spenders, and what each dot shows you is what is the mortality rate like for people who have, for example, a hip fracture or a heart attack or colon cancer. And of course, what you'd love to see is that Q5, that is the high spenders, have better outcomes than Q1, that is the lower spenders. Sadly, what you see is the opposite, that is the outcomes tend to be worse in higher spending areas. Or to put it a different way, people when they go to the doctor are no sicker going in and no healthier coming out, but they sure get a lot more care. That was the point of Atul Gawande's articles about McAllen, Texas, that Susan Dentzer mentioned. And somewhat related to that is we then do a whole wonderful stuff on medical errors. About 3% of people who go into a hospital will have some kind of adverse event happen to them. A quarter of those are negligent adverse events. A variety of the others are not negligent, but they are things that should not have occurred, things like drug interactions, or in this case, actual medical errors. SSI is surgical site infections. You have an operation, the surgical site becomes infected. We spend about $6 billion a year fixing the consequences of that. In fact, we actually know quite well how to drive these rates of errors to zero. We do it in many hospitals across the country. Despite the fact, go to any local hospital and they'll tell you there's absolutely no way that they can do anything about it. We know that that's wrong. So what is it that you do about this? Basically, if you look not even in healthcare, but you look at any industry in the economy and you say, what is it that makes an industry be productive or a business be productive? Think about the businesses that you admire most. They really have three characteristics to them. One is they know what they do. They know who's doing it, why they're doing it, how well they're doing it, how much it costs, who's the best person to do it, how do you improve the quality of doing it. They know a lot. The information structure is very good. In healthcare, of course, we know absolutely nothing. Ask yourself the question, if you wanted to have bypass surgery, would you be able to figure out which doctor is better or worse, or which hospital is better or worse? Only if you live in a small number of states. But most of the time you wouldn't, even though within those states the mortality rate across doctors varies by a factor of 8 to 1. The mortality rate across hospitals varies by a factor of 3 to 1. That is, you can go to a doctor with a 2% chance of killing you on the operating table, or a doctor with a 14% chance of killing you on the operating table. It's really your choice, but don't actually ask to find out the information. The stimulus bill that was passed last spring will hopefully address a lot of the information issues. We put $30 billion on the table to get information systems in place in medical care. Of course, having the information system in place is not the entirety of what you need. My doctor for a while had a computer on his desk. It served as a very fancy paperweight, but it was kind of nice looking. So you need the IT systems, but you also need to use it well. The other thing we know about firms that use it well is that they have compensation arrangements that reward the use of information well. That is, they reward value creation, not doing more, not doing less, not shading things, not taking gambles with other people's money, but that really do it well. That is really what the goal of this legislation is about, which is to design compensation arrangements, starting with the Medicare program, extending out into private insurance and the Medicaid programs, that really say, let's stop paying for the volume of care, but pay for the value of care, and think about not the interaction, like did the doctor recommend the right thing, or was the patient discharged with a medication instruction, but actually think about the patient as the outcome. Did the patient get better? And if the patient got better, then make that be lucrative. And if the patient didn't get better, do something else. So that's really the bulk of what it was about, is compensation. And then the third thing that happens in good firms, in good industries, is that workers and consumers are used to improve the value of care. Workers are given a lot of ability to do well in the model of probably the most productive firm, the most admired productive firm in the world, which is Toyota. Any worker can stop the production line anytime he or she wants. Why? Because they know exactly what's supposed to be done. They have the right information. They have the right incentives to do so. Other firms learn a lot from consumers. They get the feedback from consumers, and when consumers are unhappy, something changes. That's really about one way to think about what the exchanges are about in the bills that people are talking about, is learning from consumers. Firms will have a lot of work to do to free up their workers. That is, we use workers in all the wrong ways that Susan Dentzer was telling you about. That will be a very difficult challenge. This is not something like coverage where if you do it, you can do it overnight. This is going to take some while to happen, but there's absolutely no reason why it can't happen. To say it can't happen would be the equivalent of saying that every single industry in the economy can get more productive over time except the healthcare industry, which there's just absolutely no reason to believe. So on the whole, how well do the bills bills stack up, they actually stack up pretty well. There's a commitment to payment change. There's flexibility to make mid-course adjustment. There's a lot of room for experimentation on all sorts of margins. When combined with the stimulus bill and the IT infrastructure that was put out, it really lays a path for dealing with the healthcare system and the cost issues over the next 10 to 15 years or so. Like Susan, I have, and Judy and Karen, I have some complaints on the cost side. The biggest complaints I would have made are about things like sin taxes and about really freeing up the workers. I think Susan was absolutely right to note the issues about continued smoking cessation and obesity reduction, which I think are absolutely essential. I would have done more in the way of provider integration, but that shouldn't take away from the fact that that the bills really do an enormous amount along these lines. And just to finish it up, what I would see when we do this, I'm going to use when, because it's too hard to think about if. When we do this, what we're going to see is three kinds of changes happening in the medical care system over the next little bit. One is we're going to see productivity at the local level, the individual firm. How does the individual doctor's office respond? How does the hospital respond, getting rid of things that shouldn't happen, streamlining processes, making that more efficient? Second is there will be integration across providers of care. It is silly to have a system that focuses on you separately in the hospital and when you're at the doctor's office and when you're in the nursing home and when you need a home health aide and when you're taking drugs, because that's not the way any individual thinks about it. They think about their health. And so it will be integration across the ways that people think about their health. And then third is some things will have to happen regionally. We'll have to coordinate information technology systems so that firms can actually talk to each other. In Boston, we have two huge hospital systems that have wonderful, magnificent electronic medical records, and actually they can't even talk to each other. And actually, it's even worse than that. Within the systems, one hospital can't talk to the other hospital within the same system. So we're going to have that kind of coordination. Payment reform, you can't have 10,000 different payment systems going on in an area. Administrative issues, and we're going to have to work with the federal government. All of these changes will occur over time. It's not going to happen overnight, but there's a path that you can see very clearly that over the next decade to 15 years would result in a substantial improvement in the value of medical care associated with improved quality and lower cost. That's really what we should be working for.
Good morning. I want to thank the National Academy for having me here at this very important discussion. I want to focus on the issues of healthcare delivery and increasing population health, particularly for those populations that are most vulnerable, particularly racial and ethnic minority Americans. I want to submit, I appreciate the comments that came before my presentation, but I want to submit that part of our challenge around healthcare reform, when we do it, and when we do it right, is that unless we're attending to the needs of communities of color, our goals of expanding insurance coverage, improving the quality of care, and containing healthcare costs will be difficult to achieve. This is for a number of reasons. One, obviously, we're going through a rapid demographic change in the United States. By 2042, 1 in 2 Americans will be a person of color. And of course, many of these folks experience profound health inequities literally from the cradle to the grave in the form of things like infant mortality, where we see African Americans and American Indians who have infant mortality rates 2.5 times higher than national averages. We see a higher burden of chronic and infectious diseases among communities of color. And we see premature mortality. There is a tremendous human toll from this burden of disease and disability, and there's a tremendous economic consequence as well. So what I want to argue today in my 10 minutes are three things. One, we absolutely have to address the needs of communities of color as part of health reform when we do it. We need to do it both to address the human toll as well as the economic toll. And I want to argue that there are some fundamental reasons why these inequities exist. Many of them lie outside of healthcare financing and delivery. So I want to talk about some of those causes. I also want to talk about some potential policy solutions. So as we move forward, even beyond what may happen in the drama of healthcare reform in Washington over the next several weeks as this unfolds, there is another agenda that we need to attend to improve population health and to eliminate these health gaps. let me dive right into this. I'm going to try to talk fairly rapidly so that I can get as much of this in 10 minutes as possible. It's clear from a large volume of research that health inequities, both racial and ethnic health inequities, as well as those on the basis of socioeconomic status, will increase as a result of the economic downturn. When the nation's economy gets a cold, people of color get the flu. This is a truism, and it's also true literally in terms of health status. Health insurance reform, even when enacted, I'm going to be an optimist this morning, will not eliminate racial and ethnic inequities in health and health care. We saw this in the Institute of Medicine report entitled Unequal Treatment, where we documented a large body of research that shows that even when people of color present with the same health conditions as whites and when they have the same health insurance, on average, racial and ethnic minority patients tend to receive a lower quality of health care and also experience profound barriers accessing care, again, even beyond financial barriers. These include cultural and linguistic barriers as well as geographic barriers. We've noted that there's tremendous regional geographic variation in the quality of care, but it's also true that even at the level of small geographic units, even within most metropolitan cities, we see separate and unequal health care. Institutions that tend to serve racial and ethnic minority patients tend to provide lower quality care. And so we have to address this separate and unequal care as part of our effort to improve the overall quality of care. And to eliminate disparities, we have to address factors outside of the financing and delivery of health care. Community-based primary prevention, and I think that one of the things that we see in both the House and Senate bills, particularly in the Senate bill, is a strong emphasis on community-based primary prevention. It was unfortunate that in some of the debate around prevention in the context of health reform, that some chose to narrow the discussion to clinical preventive services. We're talking here about helping people to avoid getting sick in the first place, which many folks have commented on this morning, but we need a much more robust effort to improve conditions for health in communities. I want to speak about the economic imperative to address health inequities. A few months ago at the Joint Center, we released a report that attempted to estimate the economic costs associated with health inequities. In other words, what are the costs, both in terms of direct medical expenditures as well as indirect costs associated with the fact that people of color have a higher burden of disease and disability, premature mortality, and so forth. And you can easily see how this happens. If we see that people of color have higher rates of chronic diseases such as diabetes, heart disease, and so forth, what are the direct medical costs associated with that burden of disease? And in addition to that, what are the indirect costs associated with lost wages and productivity, lost tax revenue? Well, what we found was quite striking. Between 2003 and 2006, we found that over 30% of direct medical care expenditures, and we were just looking here at African Americans, Asians, and Hispanics due to limitations in the Federal Medical Expenditure Panel Survey, were excess costs due to health inequities. Eliminating inequities during this time period would have saved us nearly $230 billion in direct medical costs. And when we add the indirect costs associated with lost wages and productivity, lost tax revenue, and again, in the same time period, we find that the total bill is $1.24 trillion, which is obviously much higher than the costs of the legislation being debated in the House and Senate. I want to stress the importance of looking at neighborhoods. And here again, we have a large body of research to support the fact that we need to attend to conditions in communities, conditions where we live, work, and play. And a lot of this work was drawn into the spotlight by the very important work of the Robert Wood Johnson Foundation Commission on a Healthier America, which released a report as well as other information to highlight the fact that we need to attend to conditions in communities to improve health. We know that there are direct effects in terms of both physical and mental health of neighborhoods. Conditions such as stress, environmental exposures have direct health consequences. We know that there are indirect effects on health behaviors, which I'll mention shortly. And there are health impacts resulting from the quality and availability of care. So when we see a pattern of separate and unequal care that often mirrors residential segregation, Again, place matters for health. I want to talk about the role of segregation, which is often a topic that we are uncomfortable talking about in America, but is one of the fundamental root drivers of health inequities. When we look at levels of segregation in the United States, we see that the United States, unfortunately, is not far behind some of the most segregated countries in the world. We tend to think of segregation as a relic of the past, but unfortunately, segregation persists today. These are data compiled by demographers such as Doug Massey and others, looking at the levels of segregation in apartheid-era South Africa in 1991, and comparing those levels of segregation to several major U.S. cities. They're using here the dissimilarity index, which is the percentage of the population between two groups that would have to move to create complete integration within a geographic area. So in South Africa in 1991, they had a dissimilarity index of 90, meaning that 90% of black South Africans and white South Africans would have had to move to create integration in that country. Unfortunately, several U.S. cities are not far behind this level of segregation. My hometown of Detroit has a segregation index of 85, meaning that 85% of the population would have to move to create integration in that city. Several other cities are not far behind, including where we are right now in Washington, D.C., with a dissimilarity index of 80. Well, why is segregation important for health? Segregation is important because, on average, segregation results in the unequal distribution of resources that are important for health. So we know that segregation concentrates poverty, it excludes and isolates communities of color from opportunity structures needed for success, economic opportunities, educational opportunities. We know that there is a very important relationship between socioeconomic status and health, and segregation is one of the main drivers which results in and perpetuates economic inequality between racial and ethnic groups. Segregation channels non-whites into neighborhoods with poorer schools, fewer job opportunities, and smaller returns on real estate. So we know that real estate, of course, is a major source of wealth for most American families. The fact that a 4-bedroom home in a segregated, mostly minority community is worth less than the same home in a majority white community is one of the main drivers of wealth inequalities in this country. So I see I'm running short on time, so I'm going to skip ahead. We know that people of color are more likely to face environmental health exposures, air, water, and soil pollution, again, largely the result of segregation and the disempowerment that follows from these communities. These communities have fewer parks and green spaces to encourage active lifestyles. We know that these communities are less likely to have grocery stores. In fact, I mentioned my hometown of Detroit. Detroit now has no major grocery store within the city limits. So it does little good to preach to folks about the importance of eating fresh fruits and vegetables if they can't access those products. What do we need? A focus on prevention, particularly on the conditions in which people live, work, and play. We need multiple strategies across sectors. This is not a problem just of the healthcare delivery system or of public health. We need business leaders, faith leaders, urban planners, others all involved in helping to solve these problems. And we need sustained investment. These patterns that we see took over 300 years to develop in this country. We're not going to solve them in 1 year or 5 years. It may take a generation or more. Let me stop here because my time is up, but this is the unfinished agenda that we need to focus on past health reform. We need a much greater focus on community-based primary prevention, increasing investments in communities so that all communities can enjoy the same resources that enhance health, such as having a grocery store, having parks and recreational facilities. All of these things are important for health, and I hope to see these on the agenda for the next health reform effort in this country. Thank you.
This is a lot of fun. How might employers react to health reform? It's a challenging thing. It would have been challenging if we'd had a bill passed. But I want to take this time to speak with you because I want you to understand that employers, by and large, are behind health reform. There's some issues they have exceptions with, but for the by and large, employers have been strong advocates of health reform. I got a button here someplace. Okay. Now, employers today cover more than 170 million Americans with health care. So they're not a small player in aggregate. Clearly there are differences of employers, small, large, different approaches to things. But where we are as a nation is right now, over 170 million people, Americans rely on their employers for the health care. So employers have a role, whatever it is. Interestingly, over the last number of years, we've as employer groups, have seen various attacks on the employer-provided health system. Interestingly, as various different members of Congress have passed laws, we've had this strange sort of bedfellows over the last decade where we've seen on the left wanting to get employers out so that the people could be covered by a state-run system, and on the right wanting to get employers out so individuals could acquire health care on their own. And so you actually see some laws passed that were supported by both the left and the right that had the effect of beating down employer-provided health care. We have some unresolved issues. Obviously, no matter what is passed, even if the Senate bill is passed as it is, there are issues that we're concerned about. We sent a letter earlier this week signed by 733 employers and associations dealing with key unresolved areas that employers will have to deal with. And it's no small feat to get 733 signatures on a letter. Last week we sent a letter signed by 11 associations on some of the implementational issues, and I know there you've done a book and on the administrative solutions to health care. There are some real issues related to the administration, assuming the Senate bill was passed. How do we actually make it happen? When we look back, employers have been supporters of health reform for a long time. I personally have been involved in health reform issues for a couple of decades. I served with the Clinton administration as they were trying to work on health reform at the support of my employer, to spend virtually full time working with the administration to try to make it work. So corporations are no strangers to health reform. The American Benefits Council back in 2007 issued a report before we knew who the candidates were going to be for the next president. 2006, most of the work was done, where we issued an urge that Congress would go into insurance market reforms. We urged Congress to have an individual mandate. We urged Congress to provide for universal coverage. And insurance exchanges, we're for these kinds of things. We also want to protect the ERISA framework because that's what enables corporations to provide quality health care to so many people. We're also strongly behind quality initiatives, and it's interesting. One of the unsung pieces of health reform is that we've really been able to get language in both the House and the Senate bill that would provide an opportunity to move science a little bit away from an art form and more into a science. And let me explain that for just a minute. An organization called Stand for Quality, there's over 300 organizations that are members of Stand for Quality, including virtually every medical practice group, the hospital associations, nurses associations, industry. I serve on the steering committee, and what we did was we took this cross-section of all aspects of the medical community and said, what do we think quality ought to look like in health care? And we developed legislative language and a process to help build quality and redefine what quality is, not something subject to political whims, but rather based on scientific fact. Build robust databases that would allow tracking to see what set of conditions respond best to what set of treatments and procedures. Right now it's a guess. When I developed heart disease, I went to my cardiologist, who was rated as the #1 in my state. He says, well, guess what, Ken? There has never been a study on your set of conditions. We have no idea how to treat it. So what we're going to do is we're going to give you different medicines and try this, try that, try the other thing. We're going to test you till we get something that seems to work. We finally settled on something that works, and then the insurance agencies said that, oh, well, that's not part of the formulary. You can't take those drugs. They're not in the formulary. Well, wait a minute. It's the only one that works for me. That's not science. And I submit to you that a scientific approach would say, wait a minute, that's the one that works. We ought to do what works. And so what we've been successful in doing is putting language in the bills that would allow for the collection of long-term data for outcomes research. It has nothing to do with trying to treat people poorly or use it for rationing or anything else. It rather has to do with providing education databases that physicians and caregivers can go to and say, in this set of situations, when you've got somebody from this kind of community, this ethnic background, this gender, this set of heart disease, liver disease, whatever the conditions are, that's on average, these people have been responded better to this kind of treatment. The doctors can go off right away and start the correct treatment rather than guess. So what else? What are we concerned about? We have some concerns. We're concerned because the employer responsibility mandate, we're not quite sure how that would actually work. We're concerned about the individual mandate being weak. My son and his wife, 25-year-old couple, spend thousands and thousands of dollars for their health care. Under the community rating systems, their prices are going to go up so that the prices for the 55 and older people can go down. Some estimates say that their prices might actually double for their health coverage. Well, they would be better off paying the penalty than having insurance, because they can know that they can always get insurance if something happens and there's a guaranteed issue in it. So we actually may lose my son and his daughter and other people in their situation who have coverage today and say, I just can't afford it anymore. They can't get enough subsidy to make a difference. We're concerned about the free choice voucher, because all that would tend to do, in our view, is increase costs. There may be some places where it would be beneficial. We have to make it work. We're concerned about retiree restrictions on health care. I'm going to mention that in a minute. Some of the state remedies in the House bill and the excise tax on high-cost plans, which in the Senate bill. We are concerned about premium taxes in the health industry and retiree drugs subsidy tax. I'm going to mention that one. Class acts, we're not against class act. We're concerned about the financing. We can't wait to see what Susan was telling us about how it was going to be fixed in the financing, because that was the biggest concern employers had, was how it was financed. And waiting periods and restrictions, the definition of full-time work. That's a key one for corporations, especially those who hire a lot of seasonal workers and that sort of thing. And the public plan questions about that. A lot of questions that are unanswered. There are a couple things that I would just like to highlight quickly that are real issues for employers that happen before anything is enacted, and that depends on what gets in the bill. This one is in the House bill. It protects retiree benefits. Unfortunately, the way it's worded leaves a lot to be desired. It says that everything as of the date of retirement is protected. Well, there's some caveats on how that works, but it doesn't say as of the date of enactment. It says the date of retirement. And what do you do with somebody who's been on coverage, retired for 40 years, whose coverage started 40 years ago, because we have people out like that? What did their plan look 40 years ago? How do you know what it was? How do you know whether what they're getting today is less than what they got on the day of employment? It's almost impossible to administer. Litigation is inevitable. If companies have caps that they've had on their plan for 15 years, they're excluded. However, they're only excluded if they were in the plan when somebody retired. So somebody who retired 16 years ago before the cap was put in, well, does that a cap apply to them or doesn't apply? Companies just don't know. All they're doing is being faced with the inevitable litigation and really a lot of hassle. But they do observe that if the coverage is dropped before enactment, it doesn't count. That's not a good bill. It basically is encouraging companies to get out of the business. On the Senate side, there is one that is equally of concern, and that is that it would tax the subsidies used today and to help companies provide retiree prescription drug coverage. Congress in 2003 carefully crafted that bill to keep employers in the game. Unfortunately, now with changes in accounting rules, they want to tax that subsidy. It would have a huge impact on companies that have very large retiree populations. They would force them to take all the present value of all of their future taxes for as long as everybody lives and charge that to earnings on one day or in one quarter, and that's the day that the president signs the bill. And they have to disclose that publicly, and the only option is to get out of retiree health care. Our estimates, based on what we've seen, is as many as 3 to 4 million seniors could lose their prescription drug coverage the day it's enacted if that remains in the bill. We don't want that to happen. Issues that we're concerned about also is the timing, and that deals with the administrative stuff. The House bill would be immediate for new plans, Senate bill 6 months for new plans. Well, what does a new plan mean? Both require that you have all the states in the United States enact new laws that conform, new regulations be promulgated by both the states and the federal government. Then you have to design things, get them approved by insurance commissioners. You have to move them through, build all the systems. You got years of systems work to do. And if the laws are effective immediately upon enactment, that basically says that no new plans can exist for several years. And we don't know if new employees can be put into existing plans because they're grandfathered provisions and or we're not clear whether you can actually cover new employees. So these are things that really have to be resolved before, or else we have a debacle. Employers really do not want to have this to be a problem. They want to actually make it work. And so we're looking forward to working with, and we continue to work with members to make it happen and make it work well. Thank you.
Okay, we'll have 10 minutes for questions before we break, but I just want to make a couple of closing comments relative to the comments that were made in this. The information that each one of you had a chance to really convey in the broadest spectrum, and I think, Susan, your underlying truths, were probably more operationalized in each of our speakers relative to coverage, the whole aspect of access, whether we're talking about community determinants access, as well as quality and cost. And one of the things I wanted to share that really struck me that cross-cut all of your points is the conference that, Susan, you and I attended. And one of the attendees was the Chief Medical Officer for IBM, and Dr. Paul Grundy, who pointed out to us, which was one of those things when you brought up, Brian, that Detroit doesn't have a grocery store. IBM has actually moved its business, having studied Fisher and Company's work on high-cost areas, has actually moved one of its operating entities from a part of Florida that was one of the most high-expense areas to a low-expense medical area. And so that's how right now on the ground, I think some parts of the private sector that are national are beginning to take a look at how to, even without legislation, what they're beginning to do on the ground. So this has tremendous impact on communities relative to how the health of a community, literally and figuratively, but what companies are also beginning to do, analyzing the data as to where they're going to position their companies in order to manage their health care costs, in order to run their companies and basically operate. So that was something that just definitely struck me, that there's just multiple ways to do this. So why don't we start with our questions. Larry?
IBM, Jenny, may want to reconsider because Florida, at least in terms of real estate, is becoming rapidly a low-cost state.
That's right.
This is a very interesting and informative panel, and one of the things that struck me again, and this has happened for years, and I've been immersed in this literature like everybody else in this room, just how many moving parts there are to these proposals is just astonishing, right up to the last one in terms of the employer perspective. But this is mainly for Judy, but anybody else. It strikes me that one of the issues that we haven't talked about, although it's been implied in a lot of the discussion, including Susan's 10 points, is the power of the insurance companies. And it seemed to me as if that was most evident in the final elimination of the public option, or of the Medicare extension to age 55. And it seemed to me at the time that really struck a blow to the political potential support base for the health care reform bill. The public option, however many problems there were with it, however much criticism it was the subject of, was quite popular in poll after poll for months. And it seems to me that when it was finally eliminated about 2.5 months ago, that support began to decline. Now, there may have been many reasons for it, but it strikes me that the elimination of the public option really removed one source of leverage for the supporters of health care reform that was very important, and it was gone primarily at the insistence of the insurance industry.
Well, I think that you are accurate that the activists on health reform were most mobilized around a public plan, and that there is, I think, the disappointment on the left, inside and outside the Congress, has a lot to do with the absence of a public plan. I think that it is not solely the opposition of the insurance industry that led, although they absolutely did their level best and successfully contributed to its not being present. I think that we have, both in the White House and in the Congress, a large number of a moderate attitude that really were not fans of the public plan. As part of a strategy, might have accepted it in the White House, but that was not a primary goal, and so I think that that's part of it too. I think that in its not being present, it also, in theory, reduced a major problem with the source of opposition to the legislation, which is the primary argument on the right that this is a government takeover. And although by the time it was watered down, it was no government takeover, and never really was, taking a more moderate position, I think, was quite possibly consistent with achieving passage. Certainly moderate votes in the Senate. You just couldn't get that through the Senate. I would also say that in terms of advocacy for this bill and the left's focus on the public plan, that it allowed the obscuring of other issues in this bill, which I would argue are more fundamental. The insistence on a public plan, however value that may have been, meant that there was never a voice for adequate funding to make the subsidies as strong and the benefits as strong as they ought to be in this bill. And in my view, that reflects a greater commitment to ideology on the part of the left than to actually what was needed in the bill. So politically, I think it does diminish the turnout and the enthusiasm on the part of advocates. But I'm not sure it's what's causing the problem with the bill.
Thank you. Deb?
Thank you. I'm Deborah Whitman. I'm the staff director for the Senate Aging Committee, and maybe my claim to fame will be I was partially responsible for death panels, and maybe that'll be on my tombstone. I really want to thank Judy and David and Karen and several of you who are pointing out all of the good things that are in this bill. It is on life support right now, and if we're focused on there's this line of an employer provision that has to be changed, or there's an absence of a public option. And I understand the left really thought that was going to make a huge difference, but that wasn't really everything that health reform was about. If we're focused on what's not there, we will not do health care for another decade, and so, or generation even. So I guess, how do we get the message about what is there and why we need to not let this fail?
Well, I think you're part of it, Deborah. And you've worked hard, and the achievement on the Class Act and others is in large part due to efforts that you have made with your colleagues. I think that we just have to speak loudly, inform members of Congress, get the press to pay attention, and use all the mechanisms, including, I mean, when we talk about a demoralized left, it is not where we as a group, and not everybody in the room, but I'd go for predominance, have the most influences. Do not let the left get away with thinking that doing nothing is better than passing this bill.
Thank you very much. Okay, yes.
Hi, I'm Diane Lifsey from the National Committee to Preserve Social Security and Medicare. And I have a question for Judy, too. I mean, we've been working all along for health care reform and trying to explain to seniors on Medicare why it's important. But it's really hard, and especially with the Senate bill, to get them to understand that hundreds of billions of dollars of cuts aren't going to impact their access to providers. And when the Senate bill doesn't close the donut hole and things that are really important to seniors. But our real concern is the Independent Payment Advisory Board, and that is going to be a commission set up in the Senate bill to have cuts forever in Medicare on top of the cuts already in the bill with fast-track procedures in the Senate. And I mean, I just think that's a real stumbling block, and I'm wondering what you think about that and how you put a positive light on that.
The commission in the bill initially does set a cap on Medicare cost growth, and does significant, along with the cuts that are in the first 10 years, puts caps on growth thereafter, which to do for Medicare only, when we know that it's not that Medicare is paying too much, it's that all costs are growing too fast. I think that is a legitimate source of concern. In the Senate bill, as you know, Diane, the bill was, the commission's authority was expanded, although it doesn't. David and I had been looking at caps on everything, private, not just public, and the Senate bill went a long way to expanding the attention of any commission that exists to the whole system, as well as the commission including provisions that limit what can be done other than provider payment to contain costs. And on the provider payment side, I would say that when we look at the cuts that are in this bill, it is the opponents of the bill who are doing most to rabble-rouse to say those cuts are affecting access, because these cuts are smaller than we have taken many times in the program, where all the benefits, all that spending reduction has simply gone to deficit reduction, whereas these resources are being reinvested in health care to support other patients. And I would tell people who are concerned about these cuts that if we don't pass this bill and put them back into the health care legislation, they're going to see them. We're going to have deficit reduction. And so that will be, and Medicare will be facing the same problems without all the pressure to reduce costs in the health care system and to keep it whole. So I think seniors, too, have a stake in this legislation. I would like to see a closure of the donut hole. I'm still somewhat optimistic, because I think not only because it's the right thing to do, but because as we look to improve this, which still may be there in the reconciliation process, I think that members of Congress recognize that they need the support of seniors in the November election.
The board on top of it is just
right, and I would note that I don't disagree, but I think that there are protections in what the board can do, and that it goes more broadly. But I hear your concern.
And I'm going to have a chance to close here. Most of you have heard that I'm the president of AARP. Trust that we will continue with our ability to kind of help bring down the dial on the anxiety that has been ginned up. And so the ability to have the specifics that have come up in the course of the discussion is an area I think we have to look at the rational components of what's important to achieve in the long run. And in closure, as Judy said, let's get a grip, and let's also get ready for lunch. My request has been to have you all exit the room, so once again that they can do the luncheon. Let's give them all an appreciative thanks.